All right. We are back and hopefully you are ready. I know I am. All right. So before I get started, I gotta remind you to be an AMCI world class coder. And what is an AMCI world class coder? That's a coder that's ethical, precise, forensic, and certified. All right, so while I'm talking, I didn't get a mic check. So if you can, coders, let me know, how does my mic sound? Does my mic sound nice? Check one. All right, so I'm going to go ahead and read the copyright and let me know if I sound okay. CPT is copyright of 2023 AMA. All rights are reserved. Fee schedules, relative units, conversion factors, etc. are copyright and components of AMA. CPC is a registered trademark of AAPC, and keyword concept FTR Chun, AMCI Feb 7, Flip Tap, MCG are trademarks of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. The credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. All right, part 2 coders, what do we have in store this week? Well, last class, you all did an incredible job, incredible. And I was reading the survey and you all said, hey, I learned a lot, especially about diabetes. Way to go. We also learned about pain, psych, eyes, and adnexa. We practiced coding scenarios to strengthen your guideline knowledge, and you all knocked it out the park. This week, the goal is Chapter 9, ICD-10-CM Chapter 9, Diseases of the Circulatory System, and that's the only chapter we're going to deal with. Also, we're going to practice coding scenarios, and finally, we hope to bring you one step closer to ICD-10-CM coding proficiency. Now, I encourage all of you to follow along in your MCG. The flip chapter 9 in your MCG manual. If you're using the actual manual, go to chapter 9 in the flip portion. We call ICD-10-CM flip. It was a nickname that just kind of stuck. All right. Now, if you have the ebook, open up your ebook, type Control F, and on the left, you'll see the headings. It'll look like this. And then just click on chapter 9. All right. So if you have watched the lecture, the corresponding lecture, TAP lecture, you should be able to click on it at the end of your chapter 9. Click on it. The lecture comes up, and it's called ICD-10-CM TAP Part 5 Circulatory System, Chapter 9. And this is where you'll learn how to tap your manual, and also tap means annotate, put your guidelines next to the codes pretty much. And also, if you are having difficulty locating any of the lectures, where you see our logo, if you see our logo, it's probably where it is here on this screen, right here in the top left. Just click on that logo and all of the AMCI lectures will populate. All right, I digress. I'm back now. Let's begin our discussion on the circulatory or cardiovascular system. In Chapter 9 of ICD-10-CM, there are all of the possible diagnoses and conditions of the heart. You'll find it in Chapter 9. However, we're going to discuss the following: hypertension, CVA, cerebral vascular accident or stroke, ASHD, and AMI. All right, so let's begin with hypertension. Hypertension is relatively common in our culture. I mean, I don't know anyone, any adult who doesn't know someone that has hypertension. But we should take it serious because it means that your heart is working extra hard, and it could lead to something very serious like congestive heart failure. And I'm going to tell you, I never thought about that growing up. As I became a young adult, you hear about high blood pressure, but I didn't know it was that serious. I didn't know it was your heart. Yes, it's your heart. And that means that your heart has to work harder to pump blood when the blood pressure is high. And this can lead to the thickening of the heart muscle and it reduces its efficiency. And over time, this can progress to not just heart failure, but other conditions too, like CAD, coronary artery disease, and other cardiovascular issues. So think about it this way. Hypertension is often considered an indicator or risk factor for heart disease or heart failure. I always thought I would tell you that. Also, if you want to follow along in this discussion with your MCG manual, you're encouraged to feel free to take notes if you need to. All right? So these are not all of the guidelines, just a few, but I want to draw these to your attention. Guideline C9A. This guideline pertains to hypertension, essential or primary hypertension, and this includes high blood pressure. The code is I-10. Next guideline, C9A1. This pertains to hypertension with heart disease. Anytime a patient has hypertension and specific heart conditions such as heart failure and other heart types of heart disease, a causal relationship is presumed. Whenever you see that language, a causal relationship is presumed, it means that the doctor does not have to link them together. The doctor does not have to say they are related. No, it's presumed that they are related. And the way you sequence it, you're going to code first hypertensive heart disease, I-11, and then you're going to code second I-50 for heart failure. You have to specify the heart failure if the documentation does. So in other words, C9A1, this is the guideline for hypertensive heart disease or hypertension with heart disease. Oh, yeah, this is important. Code separately if the provider has documented that they are not related. All right, so we presume that they are related. However, if the doctor says they're not related, code them separate. I'm talking about the hypertension and the heart disease. All right, next guideline, C9A2. C9A2 is the guideline for hypertensive disease with CKD or hypertensive CKD. Oh, wait a minute, I got a little, I gotta fix this. This doesn't look right. And it's not gonna populate, even though I'm fixing it. All right. All right, I'm going to try, everybody. Let's hope it comes up. Boom, it came up. All right, so when a patient has hypertension and CKD, chronic kidney disease, not acute, but chronic kidney disease, the doctor does not have to link them. A causal relationship is presumed, meaning it is presumed that they are related. All right. So you're going to sequence as follow: I-12 from that category, followed by the stage, the CKD stage. And make sure that you read the red guidelines and instructional notes. Sorry about that. And make sure that you code separately if the provider says that the hypertension and CKD are not related. All right. Now we're going to move a little faster. Guideline C983, this is hypertension, heart disease, and CKD, all three. So this is hypertensive, heart, and CKD, and the causal relationship is presumed. The doctor does not have to link the three diagnoses. The sequencing order, I-13, that's your hypertension, your heart, and your CKD, 3 for 3. Okay, we're gonna talk about that a little later, but I just want you to see the sequencing order. After I-13, you're going to sequence your heart failure, and then third, you're going to specify the stage of the CKD. Make sure that you read your guidelines and instructional notes, and definitely code them separately if the doctor says they're not related. All right, we're getting down to the wire. C9A4, hypertensive cerebral vascular disease. Now, unlike hypertension in CKD heart and CKD and heart, a causal relationship is not presumed when a patient has hypertension in the setting of cerebral vascular disease, and documentation must specify that the hypertension and the CVA or cerebral vascular disease is related. The doctor has to link them together. The sequencing order is I-60 through I-69. That's going to be sequenced first, followed by your hypertension code. Now let's talk about coronary artery disease and atherosclerosis and angina pectoris. All right, so when a patient has coronary artery disease or atherosclerotic coronary artery disease, so that's when the narrowing of the artery is caused by plaque buildup. Let me go ahead and point to it right here. So that's called CAD or atherosclerotic coronary artery disease. You are directed to use a combination code to determine if the patient has angina or not. Okay, so angina, it's pain, it's chest pain. And the documentation has to specify it. So you don't have to determine if the patient has angina. The documentation will say it. And do not code angina separately. So if the code already has angina, then you don't have to use an angina code additionally. All right, coders, it's time. Now, before we go ahead and we start coding, I want to do a quick code lookup walkthrough for a hypertension diagnosis or a hypertensive related diagnosis, because you can have so many different types of hypertension. So I want you to see how to look it up. All right, so if our diagnosis is hypertensive neuropathy, hypertensive neuropathy. Okay, so you've got two diagnoses right there, but our main term will be hypertension, right? our main term will be hypertension, and this is what we'll do. We're going to look up hypertension. I'm sorry, nephropathy. I do that every time. Hypertensive nephropathy. I apologize. All right, so your main term is hypertension. Hypertension in the alphabetic index. We're going to scroll down until we find what? Well, what is nephra? Okay, so we can look for nephropathy, but it's probably going to say kidney, C kidney. All right, so C, not hypertension, kidney, I21, and it gives you the code I21.9. So nephro means kidney. Now, when you get to the code, you go ahead in the tabular list. This is where you're going to verify it. Make sure you read all instructional notes. Yes. So if we go to our boss, I12, and you read your includes notes, any condition in N18 and N26 due to hypertension and all of these, it includes it. It excludes the following, but let's go down to our code I21. You see hypertensive nephropathy, I21.9. Oh, that is important. I'm just trying to brush that off. You see hypertensive nephropathy. So if you didn't know that that meant kidney in this, hypertension in the setting of chronic kidney disease, now you do because it includes it. Now I want to get down to our code I12. Hypertensive CKD with stage 1 through 4 CKD or unspecified CKD. And in our case, they didn't specify the CKD. It is unspecified. So this is the code. However, there are some red notes. And these red notes below say you need to use an additional code to identify the stage of the CKD. All right, it doesn't say our stage. It just says nephropathy. All right, and that is CKD. And the stage is not indicated. So if the stage is not indicated, we're going to go to the stage and we are going to code the stage that is not specific. CKD NOS or unspecified CKD. All right. So I just wanted to show you how to look it up, but the main thing that you should pay attention to, anytime you're looking up a type of hypertension, that hypertension will be your main term. All right, let's try it one more time, okay? We have malignant hypertension with CKD stage 3. All right. All right, so the answer is I12.9 N18.30. All right, so how we do it? We're going to look up hypertension in the index. Hypertension, what type? Malignant. All right, so that is the same. You know, there's no distinction. It includes accelerated, benign, essential, idiopathic, systemic. Then you go down, you look to see, there's some instruction that tells you that when it's kidney involvement, see hypertension kidney. So I'm going down, I'm scrolling down to kidney, and there it is. Kidney with what? Well, it says stage 1 through stage 4, use I12.9. Then you go verify in the tabular list. I'm going to go to my I12.9. and it tells me to use an additional code for the CKD. And in this case, our stage was indicated. It says stage 3. So I'm going to look under N18 category, N18, and underneath, look, it says code first, any associated CKD. I'm going to do it. It's telling me how to sequence it. Now I'm going down to the appropriate CKD stage, and boom, we've got 3 types of CKD stage 3. You've got your unspecified stage, which is our case because our CKD stage was not, stage 3 was not specified. And you also have CKD stage 3A and stage 3B. Your documentation will tell you if it's 3A, 3B, or if it's not specified. So our answer, I21.9 and N18.30. Now, the moral of that story, hopefully, if you do not know your guidelines or know where to reference them, as long as you know how to look up a code, the instructional notes will point you to the correct sequencing order. And that's all I have to say about that. Now I want to check on you to see how you're coming along. And now let's test our knowledge of the HTN guidelines with scenarios. So I encourage you to use your MCG and, oh yeah, I got to tell you how to solve an ICD-10-CM scenario. Yeah, you already know it, but we'll review really quickly. All right, the first thing you need to do, highlight or inventory your diagnoses, signs, or symptoms. Also, you got to determine the first listed or your principal diagnosis code. And finally, you have to apply all guidelines. So I made these little visuals for those of you that are visual. So this will be your reference for today. We're going to use the visual. So highlight for the first one. Select your first listed. This is supposed to be the first place. And then apply all guidelines. All right. Highlight first listed guidelines. All right, here is the scenario. Of the following answers, which best describes the encounter? A, I-10, Z96.6, B, Z96.6, R03.0, C, I-10, D, R03.0, Z96.6. Jeanette arrives at her ortho appointment to find out if she will need to have another procedure to remove her Cartiva implant. Upon arrival, Jeanette's blood pressure was 150/70. The physician examined the patient and determined that the implant had not dislodged and no treatment was needed at this time. He also diagnosed the patient with transient HTN and told the patient to follow up with her PCP for further evaluation. All right, coders, is it A, B, C, or D? Your time begins now. You all did a great job. You did. You all tried. Majority of you didn't really get this one, but some of you did. All right, we're going to have an aha moment, and that is priceless. My keywords: remove Cartiva implant. The implant had not discharged, and the patient was diagnosed with hypertension. All right, coders. What guideline did you apply? Or did you? Go ahead, type in the chat. All right, I see some people putting some answers in. All right, so if you said C9A7, outstanding, that's the guideline. Yeah, hypertension, transient, right? This patient was diagnosed with transient hypertension. And it basically says assign R03.0 when the patient has elevated blood pressure reading without diagnosis of hypertension. All right, so this patient was not diagnosed with hypertension. The patient was diagnosed with transient hypertension. Another word for transient hypertension is white coat syndrome. In other words, sometimes your blood pressure can just be risen, well, it can raise because of stress. So, just by virtue of being in that doctor's office and seeing that white coat, their blood pressure goes up. So they don't necessarily have hypertension. So, and that's what transient hypertension is. It's not hypertension, it's just elevated blood pressure. And it tells you to sequence it first. However, we have a situation here, and probably you might want to take that first off. You're going to sequence according to the reason for the encounter. I'm going to adjust the MCG to say sequence in accordance with the reason for the encounter, the RFE. And you can blame it on the MCG if you got it wrong. Now, what's the RFE, coders? Why did that patient come? That's what's really going to determine the answer. All right? So because the patient does not have hypertension, we can eliminate A because it's coding for hypertension, I-10. We can also eliminate C, I-10, right? Patient doesn't have hypertension. So we need to determine what is the chief RFE, and that will be our answer. Well, this patient came in because she wanted to know if she had to have her implant removed. The doctor examined that patient and said, hey, all looks good. So they probably did some um, x-rays and whatever they needed to do to determine that that implant had not dislodged. So at this point, that still doesn't tell us what is the chief reason for the encounter. But what it does do, it gives us an opportunity to have a grown folks conversation. Do you think this patient would go to an orthopedic doctor for a blood pressure, or HTN? No, the reason the patient walked through the door was implant. She wanted to check the status of her implant. Now, if that practice first listed transient hypertension as the reason for the encounter, to substantiate medical necessity for that orthopedic visit, That practice is going to have some explaining to do because it will not substantiate medical necessity. What will substantiate medical necessity for that orthopedic visit is that Z96.6, and that is the status of a joint implant. All right, Cutters, are you with me? Someone said, denied. Absolutely. You can use status codes if they are pertinent and if in the absence of a diagnosis as well. Absolutely. Good job, coders. And if you, not to be off topic, but I see this so much, I get so many questions about this. Do you think AI is going to take over our coding jobs? No. This is a prime example. AI just doesn't have common sense and they need coders to help them along. AI is going to help coders with volume, but AI can't code. I can't see how, when, I mean, one day, maybe years and years and years and years, but right now they can't. And you know what? If you ask AI, they're going to tell you, we can't code. They'll tell you no. Okay. All right. So again, follow along in your MCG manual for the remaining and make sure that you apply the guideline. And don't forget to adjust this guideline. Just say sequence RFE first. All right. That's what I'm going to do for 2024. So if you said B, outstanding. All right. We got another scenario. You ready? All right. Okay, so don't forget what you have to do. Highlight your key terms, select your first listed, and check all guidelines, apply all guidelines. Which answer best describes the encounter? A, I-10, E11.8, K21.9, I50.9. B, I50.9, I11.0, E11.9, K21.9. D, I11.0, I50.9, K21.9, E11.9. And D, I10, I50.9. Thomas arrives at his PCP's office with complaints of chest pain and edema. The physician did a full body workup and diagnosed Thomas with HTN, GERD, diabetes mellitus, and congestive heart failure. Okay, coders, hopefully this clock will work and your time begins now. Come on, coders. You can do it. Okay. Now those answers are starting to come in. Good job. Trust yourself. Coders, what guideline did you use? Type it in the chat, and while you're doing that, I'm going to highlight my keywords. All right? Chest pain and edema, hypertension, GERD, diabetes mellitus, and congestive heart failure. All right. So you know what I'm going to do? I'm going to grab a guideline. I see some guidelines in there. You all saying C9A1 outstanding. C9A1. All right, coders. This guideline is pertinent. This is hypertension with heart disease. As you can see in this encounter, patient was diagnosed with hypertension, also congestive heart failure. So when you have hypertension with congestive heart failure, you should sequence it in the following way. Now, you might say, well, not all heart diseases should be, considered hypertensive heart disease. You're correct. But in the guideline body here, it specifies the code range, right? So our diagnosis of congestive heart failure falls under this code range. All right. And when you have hypertension in the setting of congestive heart failure, it is indeed hypertensive heart disease. You're going to sequence first I-11 followed by I-50 category. So if we look at our answers, what's sequencing properly? So if you look at A, right away we have to eliminate it because it's only coding for hypertension, not hypertensive heart disease. You got to go. What about B? Indeed, it's not sequencing correctly. It's sequencing the heart failure before the hypertensive heart disease. So that has to go. And look at D. D is coding only for hypertension, not hypertensive heart disease. So we're going to get rid of D, we're going to get rid of B, and C is our answer. Hypertensive heart disease, heart failure, GERD, and diabetes. What are you doing, Mrs. J? I'm having an adult conversation because you all are amazing. But for those of you that need it broken down, here you go. Well, when you have hypertension, you can just go, when you have like 4 multiple choice answers, go ahead and go to your code series and start with hypertension. And if you look at I-10, hypertension, mine is chunned a little bit. Also, I-11 is hypertensive heart disease, and it includes any condition in the I-50 or I-51.4 through I-51.7 and I-51.89 and 9 due to hypertension. So in other words, this is hypertension with heart involvement or heart disease. And I-10 is not correct because it's not accounting for the heart. And I-11 is. So we're going to get rid of A. And underneath the code I-11.0, hypertensive heart disease with heart failure, it tells us to use an additional code to identify the type of heart failure. So it's telling you code additionally. Anytime you see language that says code additionally, it means code after, code after. All right. So let's go ahead and verify that heart failure code. Here it is, I50.9, heart failure unspecified. Indeed, the type of heart failure has not been specified, so this is indeed our code. And if you look down and you see these supplementary terms, you see congestive heart disease, congestive heart failure. And to just kind of be, let's go ahead and do the coding all the way through. You have your diabetes type 2 code without complications. It's non-specific diabetes type 2. This is correct. And then also your GERD, K21.9, gastroesophageal reflux disease without esophagitis, esophageal reflux disease. So C is our answer. All right, how are you all doing? Okay, someone said okay. All right, all right. Someone said pretty good. That's good, but I want to see more response. I'm talking to everybody. Everybody, let's go. Now it's time for exercise 3. An echo and cardiac stress test reveals hypertensive heart disease with left ventricular failure. A. I10, I50.1, B. I11.9, I50.9, C. I11.0, I50.1, and D. I50.1, I11.0. A hypertensive patient comes in with complaints of chest pressure, some fatigue, and ankle swelling. All right, coders, your time begins now. You all are rocking. If you don't mind, I really don't think you need 2.5 minutes on some of these. Okay? All right. So we're going to just kind of move things along. And you are rocking the chat. Yeah. So hypertensive heart disease with left ventricular failure and also chest pressure. All right, so which guideline did you go after? It's the same one, C9A1. When you have hypertension in the setting of heart failure, it's hypertensive with heart disease, and that we're going to sequence this I11 followed by I50. And anything that's not doing that is going to be eliminated. So we're going to eliminate A, that's sequencing I10, that's general hypertension. They're sequencing that first before I-50, and D is wrong because you don't sequence heart failure before the hypertension code. So that leaves us with B and C. So that sequencing order is key. It's going to help you save time. It really is. So you don't even have to consider A and D because it's sequencing incorrectly. See? Now, let's go ahead and look up these codes. If you look it up, it'll tell you the proper way to sequence. All right, so we go to the I-11 category. This is the hypertensive heart disease. Let's look at these codes carefully. I-11.0 is the code for hypertensive heart disease with heart failure. Yes, left ventricular failure. So the left ventricular is failing. That is heart failure. And underneath it, it tells you to use a code to identify the type of heart failure. It's within the I-50 category. I-11.9 is hypertensive heart disease without heart failure. And you see there's no instructional note to code the type of heart failure because this is the code for without heart failure. So the only code between B and C is correct, is I-11, C, I-11.0. Now let's go ahead and do our due diligence and let's look up this heart failure, all right? And underneath, look at it, it tells you to code first. So if you're thinking about coding this heart failure second, the instructional notes say, hey, code first, heart failure due to hypertension. And then we go down, we're going to find our left ventricular heart failure code, I-50.1. So if you said C, and a lot of you did, outstanding. I think all of you said that. Outstanding. All right, so we're going to pick up the pace just a little. All right, and we're now on exercise 4, and I gave you the keywords. Okay, so the patient currently receives dialysis. A, I-10, N1 8.6, Z99.2. B, I-1 3.2, N1 8.6. C, I-1 2.0, N1 8.6, Z99.2. And D, I-1 2.9, N1 8.6, Z99.2. A patient is admitted with hypertension and end-stage renal disease. The patient currently receives dialysis. Okay, coders, your time begins now. What say you? Okay, coders, what say you? I see the alphabet. That's what I see. All right, coders, what guideline did you reference? Okay. Oh my goodness. I reference guideline C9A2, and right away I'm able to eliminate A and B. Here's why. If you go to the third column here, it says sequence first I-12 because we're talking about hypertensive chronic kidney disease, right? The patient has end-stage renal disease. This is the final stage, and the patient's on dialysis. So they indeed have CKD. And when you have CKD with hypertension, I-12 is your first listed code. Now you have to grab your code from I-12 category, and you also have to sequence second, the stage of the CKD, and then third, any acute renal failure if applicable. Not applicable in our case. There you go. So that leaves us with C and D because C and D have the correct category. They have the correct boss. So anytime it's like that, you know you have to look up in the tabular list. All right, so we're at the I-12, hypertensive chronic kidney disease. It includes any stage N1-8 and N2-6 due to hypertension, atherosclerosis of kidney, atherosclerotic nephritis, hypertensive nephropathy, and nephrosclerosis. All right. So what we have to do is distinguish C and D, and the difference, 0.0, I12.0, this is the code for hypertensive CKD with stage 5 or end-stage renal disease. Keyword, end-stage renal disease. And I just kind of wrote it a little bigger. I said hypertensive CKD with stage 5 and end stage, just so I can see it. You don't have to do that because it's written here in green. I12.9 is stage 1 through 9 and also unspecified CKD. So I12.9 cannot be the correct answer because we have end stage CKD. And that Z99.2, when you look up your stage of CKD, CKD requiring chronic dialysis, use additional code to identify the dialysis status, Z99.2. So end-stage renal disease is N18.6, and they direct you to use an additional code to identify the status. So if you said C, outstanding. Man, those C's are running today. All right, let's see if we can do something else. All right, how'd you do? I saw a lot of people got it, didn't get it, but if you had an aha moment, that's priceless. Let me see. You have an aha moment? Type in the chat. Look, someone said they didn't even look up the code in the book. They used the process of elimination. You're developing the skill. Outstanding. Outstanding. I'm glad you always have an aha moment. All right, exercise 5. Which ICD-10-CM code best describes the above encounter? A, I16.9, I12.9, N18.9, B, I16.9, I12.9, N18.4, C, I12.9, I16.9, N18.30, and D, I16.1, I12.9, N18.4. A 32-year-old patient presented to his provider complaining of mild headache and fleeting back pain. The patient is on medication for hypertensive stage 4 renal disease. After several blood pressure readings in the office, the doctor determined the patient was experiencing a hypertensive crisis and admitted the patient because the patient's blood pressure remained elevated at 210 over 122. At bed rest and the administration of IV antihypertensive medications, the patient's blood pressure decreased and the patient's symptoms gradually improved. Okay, coders, what say you? A, B, C, or D? All right, we only got a few answers in the chat, so I'm going to give you a little more. Okay, they're starting to come in. Good deal. Good deal. Good deal. And a key, grab the guideline. Grab it from your MCG manual. They're right there. All right, so I'm going to move on and I'm going to go ahead and highlight my keywords. We have a mild headache, fleeting back pain, hypertensive stage 4 renal disease, patients having a hypertensive crisis, and the blood pressure was elevated. All right, coders, which guideline would you apply? And I would apply guideline C9A10 for hypertensive crisis. Key word in our documentation. When there is a diagnosis of hypertensive crisis, whether it's urgency or emergency, code first I-16. And you're going to sequence according to the reason for the encounter. All right. So we do have a crisis. This is the reason for the encounter, right? So look at that I-12. They're sequencing that first. Nope, we're going to get rid of you. And that leaves us with A, B, and D. Now we have to look up the codes, and I think when we look it up, it's going to give us our answer. So let's start with I-16, hypertensive crisis. If you look at I-16.0, this is hypertensive emergency. I-16.1 is a hypertensive emergency. One is urgency, one is emergency. What is the difference between the two? Well, that is a good question, but I'll answer that after we look at the hypertensive crisis unspecified. And if you look at your guideline, it says hypertensive urgency or emergency is a hypertensive crisis. So, in other words, the doctor did not specify if it was an urgency or emergency. Doctor did not say. The doctor just said the patient was having hypertensive crisis. All right. So because the doctor wasn't specific, I-16.9, that's the direction I'm going. Now, if you want to know the difference, both hypertensive urgency and emergency, both occur when the blood pressure is elevated, as in our case, 210 over 122. So they're both urgent and emergent. But what distinguishes the two? Urgency does not involve an acute organ dysfunction or disease, but emergency does. And if you look back in our documentation, you see that we have hypertensive stage 4 renal disease. This is not acute, it is chronic. This is a chronic condition. All right, that's chronic CKD. All right, so let's go ahead and let's eliminate I-6.1. And that leaves us with A and B. So let's look at it. And what's the difference? Well, they both are coding for the CKD. A is coding N18.9. That's your non-specific stage. And N18.4, this is stage 4 on site, we can tell. So let's go over here to this part of our page. At the top, you do see your hypertensive CKD. You know that I-12.9 is CKD for stage 1 through 4, or a stage that is not specified. That will be our second code. How do you know? You know it's our second code because underneath it says use an additional code for your CKD stage. Now let's draw our attention to our CKD stages. N18.4 is CKD stage 4, and N18.9 is non-specified CKD. Okay. So our answer is B. And if you said B, outstanding. Exactly. Someone said when it's not documented, 0.9. Outstanding. It's okay if you press the wrong word. We knew you all are doing an incredible job. All right, how you feeling, coders? We're on exercise 6. We're getting down to the wire. Someone said, okay. I want to know who's feeling good and who's not. Another okay. Someone's pretty good. All right, so trust your MCG. It will guide you. It will. All right, which codes best describe the above encounter? A, I-10, B, I-11.9, I-50.9, C, I-11, D, I-16.9. Sorry about that. We got to fix that. I-16.9. All right. Misty is a 63-year-old with uncontrolled hypertension who presents today for her to her nurse practitioner for a follow-up exam to check her response to a new antihypertensive medication. Although improved, her blood pressure remains mildly elevated at 130 over 88. Her provider adjusted her medication and will see her back in 2 weeks. Which codes best describe the above encounter? Okay, coders, your time starts now. I'm only going to give you a minute for this one. What say you? All right. I said I was going to give you a minute, but I didn't see those answers come through. Yes. Come on through. Come on. Don't be. Look, we're not going to say your name. We won't. This is between you and me right now. All right. So, my keywords: uncontrolled hypertension, blood pressure remains mildly elevated. The guideline that I referenced was hypertension uncontrolled, C9A9. And you apply this guideline when there is a diagnosis of uncontrolled hypertension. This means the hypertension is not responding to the medication or treatment. And it says use the traditional hypertension code. So we need to determine which hypertension is applicable. All right, so pretty much this patient just has hypertension that's not controlled. No other type was specified, right? Yeah. So let's go ahead and see. I-11 is hypertensive heart disease. No mention of heart in this documentation. So anything coding from the I-11 category has to go. Also, heart failure is the I-50 category. There's no mention of heart involvement whatsoever in this documentation. So anything that is coding for I-50 is incorrect. Also, hypertensive crisis, I-16 is also incorrect. There's no mention of a hypertensive crisis. So anything coding for I-16 has to go. But I-10 is correct. This is primary hypertension. It includes arterial, benign, essential, malignant, primary, systemic. This is indeed our hypertension or hypertension NOS, right? So B has to go, C has to go, D has to go, and our answer is A. Boom, that's right. They said, Mrs. J, drop the mic on that. Indeed. But you all, if you had an aha moment, that's the ultimate mic drop. So drop it. Just drop it. All right, exercise 7. Way to go, coders. Let's keep this going. He has coronary artery disease with unstable angina. A, I25.110, I20.0, Z89, Z87.891, B, I25.110, Z87.891, C, I25.110, F17.210, and D, I25.110, Z72.0. A former smoker is seen for follow-up, and he has CAD with unstable angina. What say you? Your time begins now. Okay, how are you, coders? How are you doing? You guys are killing it. Look at that. Boom, 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 boom. All right, first things first, I'm going to highlight my keywords. Former smoker, CAD, unstable angina. And the guideline that I referenced was C9b, atherosclerotic coronary artery disease, ASHD, and that's also CAD, and angina. And the guideline says, and it's here on the bottom. Sorry about the quick transition. But the guideline says you're going to sequence first from I25.11 ASHD with angina or I25.7. So I'm looking, all of our answers have I25.110 here. And this is atherosclerotic heart disease of the native artery with angina pectoris. But if you look underneath the sequencing order, there's some guidance. It says do not use a separate angina code. And that makes sense. Anytime a condition is included in the code, you should not code that condition separately. You can't code it additionally because it's already included. I also want to draw your attention to the top where it tells you to use additional codes to identify some things. We're going to come back to that, but I also want to draw your attention to the answers. They all have additional codes, and those additional codes can be found here. I digress, but I'm coming back to this guidance where you do not code in addition something that is integral or already included in the code. So if you already have a code here that says with angina, without angina, but with angina, you're not going to code an additional angina code. We're not going to code them both. And that's what this do not mean. That's what the do not means. So do we see something coding for unstable angina with AHSD with angina? Yeah, A. A is coding for the CAD and the angina. So we're going to get rid of it. And that leaves us with B, C, and D. And all three have different secondary codes. And that brings us here. It says use an additional code to identify, and I'm looking at Z98.891, and it's here. It says history of tobacco dependence. All right. History means, in the context of ICD-10-CM, that means that person no longer. It's history. They no longer do it. All right. F17.210, F17 category, that F is a psychiatric, it's the mental health category, and this is tobacco dependence. And Z72.0, this is tobacco use. So of the three, history, dependence, or use, our smoker is the former smoker. So history is the best answer of the three. So let's go ahead and get rid of the wrong answers. C for dependence and D for tobacco use. And our answer is B. Wonder how that happened. Hmm, hmm, hmm. I was trying to give you all a visual. So they may not be in the correct order, but I've done my best. All right, so if you got that correct, coders, outstanding. All right, so now we're going to leave hypertension, and here are my final thoughts. All right, so you see the hypertensions on the left. Those are the categories. I10, I11, I12, I13, right? I10 is hypertension with no specified diseases. This is a zero, or it's supposed to be zero. No specified diseases. In other words, it's just hypertension all by itself. The zero means zero specified diseases. I11 is hypertension in the setting of heart disease. How many hearts do you have? You have one heart. I12 is hypertension in the setting of kidney disease. How many kidneys do you have? You got two. And I13 is hypertension in the setting of heart and kidney disease. In other words, you have three conditions. You have hypertension, you have heart disease or heart failure, and you have kidney, CKD. You have all three. So in sum, this is a way to understand or know the differences between the categories on site. So hopefully that'll help you. And sorry about my visual, but hopefully it helps you and it makes sense or it speaks to you. Now we're going to leave our discussion on hypertension, and we're going to turn our attention to acute myocardial infarction. Acute myocardial infarction, what is it? Well, it's a heart attack. Yes, it's a heart attack. So there are a few reasons that a heart attack occurs, and we're going to talk about them very soon. But one of the most common is the buildup of plaque that restricts the blood flow. And if that blood flow is restricted to a point where the heart can't get the blood and no circulation takes place, that tissue can die. Like right here, it can die. And that's permanent. Yeah. So heart attacks are important. Heart attacks are coded a particular way. And there are a few types of heart attacks, but the common are your STEMI and your non-STEMI. STEMI and non-STEMI. Your STEMI over here results from a complete and prolonged occlusion or blockage of an epicardial or coronary vessel. And the way it's diagnosed is on a ECG. So like right here, see the ECG. And I'm going to show you how to read one of these. We're going to try. Now the NSTEMI on the left usually results from severe coronary artery narrowing and transient occlusion. They are not the same. All right, so the meaning of the terms. A STEMI is ST elevation myocardial infarction, and an NSTEMI is non-ST elevation myocardial infarction, and that's key. It is. All right, so we're going to learn about the different parts. This is real quick. It's not long. All right. So these waves, this is like an EKG. This is like a little blip of an EKG. And these waves have meaning. You've got your P wave. This represents the electrical activity of the atrium up top, the top chamber of the heart. The Q, the R, and the S complex, all three together, represent the electrical activity of the ventricles. Now your T wave over here, this represents the electrical activity of the ventricles as they relax. And then there's a little U wave, you don't really see it. It's a small wave that sometimes follows this T wave, and its exact purpose is not known. Now, what's important in determining if a patient is having a myocardial infarction, an acute myocardial infarction, is this portion right here, the S and the T segment, this portion right in between S and T. We call it the ST segment, right? And so see this line here? This line is called an electro, excuse me, no, an isoelectric line, an isoelectric line. It's the baseline or the resting point. And when this ST segment is elevated, in other words, if that ST segment wave appears above this isoelectric line, it's called an ST elevation, myocardial infarction, or a STEMI. And if that wave, this ST wave, is depressed or appears below the isoelectric line, it's called a non-ST elevation myocardial infarction. Are you with me, coders? Okay, I got one person that said yes. Because you got to be paying attention. Because we have a little exercise. Okay, cool beans, like someone said in the chat. All right, so I want you to tell me. When I point to it, is it normal? Is it a STEMI? Or is it a non-STEMI? All right, remember, normal is it sits on the isoelectric or the baseline. It sits on that, the ST segment, all right? So you can see the ST segment, and I'm going to put a little line there. Is this normal, or is it a STEMI, or is it a non-STEMI? Type your answers in the chat. Yes, yes, yes. All right, so we're only talking about the ST segment right here. It's normal. Outstanding. All right, so now here is the baseline. Is this normal? Is it a STEMI, or is it an NSTEMI? And we're talking about the ST segment. ST segment. Is it normal? Is it a STEMI, or is it a non-STEMI? All right, a STEMI is when the ST segment is elevated. Elevated, and this is elevated. So it's a STEMI, ST elevation, myocardial infarction. All right, and below, here's your baseline. All right, is it a STEMI or a non-STEMI, or is it normal? Good deal. You guys are rocking. You saying it's a non-STEMI. Yes, it's below the ST segment. This portion here is below the baseline or the isoelectric line. All right, take a stab at the one below. Is this a normal, STEMI, or non-STEMI? This is the baseline. And this is your ST elevation, like right in there. Yeah, it's a non-STEMI, but it's inverted. See? It's a non-STEMI. Good job. So now when you get to the hospital, you can look at this tape and see the line here. You can say, okay, I can see it. All right. So this is normal. That's normal. ST is elevated there. Over here, the ST is elevated here. Right here. Oh, wait, that looks normal. And that looks normal. And then this looks normal. And this looks slightly elevated, so that's a STEMI. This is also a STEMI, and this too is a STEMI. Congratulations, coders! You can now say that you understand just a little bit what that ECG means. Way to go. Now we have a guideline. This guideline says that when the STEMI is a type 1, excuse me, when the non-STEMI ST elevation is type 1 C9E1, if a STEMI, non-STEMI evolves to a STEMI, make sure that you code the STEMI. If a non-STEMI evolves to a STEMI, code the STEMI. Just want you to know that. All right, so here are some key guidelines when coding a heart attack. All right, so these heart attack or these myocardial infarctions are coded according to the type and the location of the infarction, which is reported with the 4th and the 5th character, right? So if the site of the infarction is not specified, I to 1.9. I think if the type and the site is not specified, it's I to 1.9. If it is 100% non-specific, I to 1.9. If your documentation just says um, says heart attack, I to 1.9, acute myocardial infarction, I to 1.9. However, if the type 1 AMI and the site, if the type 1, if a type 1 AMI and the site is not specified, then you code it I to 1.3. All right, so if the documentation says this is a type 1 AMI, it's I to 1.3. All right, so they didn't specify the site of the infarction, where on the artery, or where in the artery did the infarction occur. And I to 1.9 is 100% non-specific. All right. The other thing I want to talk to you about are the types. I keep talking about type 1, type 2. Now, these are all of the types at a glance. Type 1 is your most common. This is where your STEMI and your non-STEMI falls. These are your spontaneous myocardial infarctions, and they're related to plaque erosion, like plaque buildup occlusion, and or ruptures, fissuring, or dissection. The code series is I to 1.0 through I to 1.2 and I to 1.3. And if it's a STEMI, that's the code series. And if it's a non-STEMI, the code series or the category is I to 1.4. Now, type 2 is your myocardial infarction due to demand ischemia. This is coronary artery spasms or coronary embolism, anemia. Myocardial infarction secondary to ischemic balance. What is that? Well, this is the supply of blood to the heart is not limited to, well, it's not limited, but it is inadequate to match the increased oxygen demand. So, what your body is demanding, if your heart is unable to supply it, then that is a form of demand ischemia. And if it's diagnosed as demand ischemia, your code is I21.A1, or you're going to sequence your underlying cause. It just depends on the RFE. You have to read your TAP, read your guideline. All right, so you've got type 3, and it says types 3, other myocardial infarction associated with revascularization surgery. So if a patient has to have this revascularization surgery, it's because they aren't candidates for other interventions. So they may have have conditions that don't permit them to have the standard procedures. Also, MI due to sudden cardiac death when no biomarkers are found. And if those are the case and it's a type 3, you're going to code it from I21.A9, other myocardial infarction type. And then you've got your type 4, A, B, and C. 4A is related to PCI, that's percutaneous coronary intervention. When you get to part 3, you're going to learn about those procedures. Those are like stents and balloon angioplasty, etc. 4B is a myocardial infarction related to stent thrombosis. So there is a blood clot in the stent. Also, 4C, myocardial infarction related to restenosis, okay? And type 5, this is a myocardial infarction related to CABG. So that means that they had a rewire, that they, when you get to part 3, you're going to talk about CABG. It's coronary artery bypass grafting. So the infarction is within the graft. All right. Now, let's talk about myocardial infarction and the duration. An initial or acute myocardial infarction lasts, the duration of it is 4 weeks or 28 days or less. Anything 28 days or less is considered acute. All right. Now, subsequent myocardial infarction, it occurs within that 28 days or less. So a subsequent infarction occurs within the 4 weeks or 28 days of the previous infarction, regardless of the site. Not all subsequent, but it is considered a subsequent infarction if it occurs within the 4 weeks or 28 days. Now, an old myocardial infarction is considered as having occurred longer than 4 weeks. All right, so it's important that you understand the differences, and I have a little chart on how to code type 1 AMIs, how to code a STEMI or a non-STEMI. All right, so when you're coding a type 1, you always have to know why the patient came, right? So why did the patient come to the ED? Well, they came for, let's say they came to the ED because they were having an acute myocardial infarction. If that's the case, this is how you code it. Well, you got to ask yourself, did this patient have a previous AMI? If the answer is no, you're going to code from the I21 category. If the answer is yes, then you're going to code sequence I22 category first, then you're going to code I21. All right. And then you're going to have to ask yourself, did they have an old MI? And if the answer is no, you do nothing. If it's yes, you're going to sequence it this way. I21 first, and then I25.2 second. And also, you have to pay attention to whether or not it's a STEMI or non-STEMI. And when you see the RFE language, that means reason for encounter. All right. Now, what if the patient came in due to something else and then had a heart attack in the hospital? So, if the reason for the encounter is other than an AMI in the setting of an AMI, an AMCI, then this is how you code it. All right. So they came in with a headache, a splitting headache, and then while they're there, they had a heart attack. If they've never had a previous AMI, you're going to sequence the reason for encounter first, the headache, the splitting headache, followed by I21. Now, if they had an AMI previously and that AMI is not older than 28 days, then you're going to sequence first the reason for the encounter, second, I22, and third, I21. And if that AMI in the hospital is older than 28 days, let's say they had one before, but it was older, then first, you're going to sequence the reason for the encounter, and second, you will sequence I12 or I25.2. All right. Now I have an exercise, and then I'm going to hand it over to Mr. Sandeep. The EKG showed an acute posterolateral myocardial infarction. All right, so I guess this is a full one. There are no options, multiple choice. So a patient was brought into the ER with complaints of chest pain. The EKG showed an acute posterolateral myocardial infarction. All right, coders, we're going to walk this together. All right. So this posterolateral myocardial infarction, that is the muscle, right? That's the muscle where the damage occurred, right? All right, just thought I'd let you know, muscle. All right, so my keywords: chest pain, acute posterolateral myocardial infarction. So we need to use this chart. And we need to ask, was there a previous AMI? If the answer is no, then you're going to code from I21 category. If the answer is yes, then you're going to determine if it's older than 28 days. If it's not, you're going to sequence I22 first, followed by I21. If it's older than 28 days, we're talking about that old myocardial infarction. You're going to sequence first I21, followed by I25.2. All right, coders, this is how I did it. First things first, I looked up infarction. Infarction of what? Infarction of the myocardium. What part of the myocardium? I scrolled down and it was posterolateral right here. Posterolateral. And if you look under, since we know new stuff, we know what ST elevation is, right? Yeah, this is type 1 ST elevation. This patient had a STEMI of the posterolateral wall, I21.29. That's my default. Now I'm going to go to my tabular list and verify. I21.2 is ST elevation myocardial infarction of other sites. And then under 2.1, ST elevation involving the posterolateral transmural, that Q wave, infarction acute. Mm, mm, mm. There we go. We're learning stuff. All right, and the answer is I21.29. All right, coders. I see an aha moment. I see one. All right, so Mr. Sandeep, please and thank you.
Thank you, Ms. J, once again for those awesome, great scenarios and a great review of the guidelines. So, coders, I will take it from here. And now it's time. Let's do some testing on our AMCI guideline. And yes, so there is no option for this question for you guys. And I will give you 3 minutes to solve this one. And the question is, a patient was admitted with acute myocardial infarction. 10 days later, he was admitted for acute anterior lateral infarction. And your 3 minutes to solve this question starts now. Okay, coders, that's your time. And I can see only few answers in the comments. Come on, coders, place your answer. Give your best shot at this. Even if you get it wrong, don't worry. We are all here learning. And if you get it right, or if you're learning something, it's priceless, as Miss J say. Okay, now I can see the answers coming. So let's do this one together. In that case, the patient was admitted with acute myocardial infarction, 10 days later admitted for an acute anterolateral infarction. So we have a patient with an AMI, which is acute myocardial infarction. Just after 10 days, he was again admitted for an acute anterolateral infarction. Now let's take our table and ask the question, was there any previous AMI? Yes, is the answer. And how old was that? Was that older than 28 days? No, it was just 10 days back. Yes, so we are going to have two codes here. The first one would be for the second AMI, the reason for the encounter. That is for acute anterolateral infarction. That must be coded first. That must be sequenced first, followed by the second code, I-21, which is for the initial AMI. Okay, so with that in mind, let's go and look at the code. Let's take the alphabetic index and let's look under the main term, infarction. Under the infarction, we go to the myocardium, and under myocardium, we comes to the subsequent or recurrent reinfarction. And that's not specific. We have to be more specific. Where did we had an infarction? It's at acute anterolateral location. So we come down and anterior wall over here, we can see that it's coding for anterior apical, anterior lateral, and anterior septal wall. So that code is going to be I-22.0. Now we have to cross verify with our tabular list, and we will take our tabular list and go to I-22.0. That is coding for a subsequent ST elevation myocardial infarction of anterior wall. And over here, we can see it also includes a subsequent anterior lateral transmural infarction acute. So that is going to be our first code. Yes, that's going to be the first code. And next we have to code for the initial AMI, which happened just 10 days before. For that, once again, we will go to the alphabetic index. Under the infarction, we'll check for myocardium. And over here, you can see, yes, myocardial acute with stated duration of 4 weeks or less. Yes, that exactly what we are dealing with, and that code is going to be I-21.9. Cross verifying with our tabular list, we can get the answer. Yes, I-21.9 code for acute myocardial infarction, unspecified, and our second code is going to be I-21.9. So the answer is I-22.0 and I-21.9. How are you feeling, coders? Are you following? Yes, awesome, great, great. Now let's do another exercise. Are you ready? This time you guys are going to nail it. So are you ready? Yes. And this is exercise 9, and your answer options are option A, I-22.8, I-21.09, option B, I-21.11, I-22.0, option C, I-22.0, option D, I-22.0, I-21.11. 2 days after being admitted for an acute myocardial infarction of right coronary artery, the patient suffers a new anterior apical myocardial infarction. The patient is being seen for the new infarction. So coders, you got 2.5 minutes to solve this one, and I know you are going to rock this one. And your time starts now. You all are getting there, yes. So the keywords here: 2 days after acute myocardial infarction of right coronary artery, a new anterior apical myocardial infarction. Now, what's the reason for encounter? Patient is here for the treatment for the new infarction. Yes. Now let's take our table and let's ask the question: was there any previous AMI? Yes. And how old was that? Was that older than 28 days? Yes, it's less than 4 weeks. It's just 2 days before the patient had an acute AMI of right coronary artery. So once again, we are going to have two codes here. The first one for the current for the second AMI, and the second code would be for the initial AMI. Yes, so with that guideline, I can eliminate option B on site because it's following a wrong sequencing order here, isn't it? Yes. And I can also eliminate option C because it's not even coding for the initial MI which the patient had. So I eliminated two of the options on site even without looking what they are coding for. Now only remaining two options are A and option D. So let's have a look into what option A and D are coding. Option D is coding for I-22.0, that is for subsequent STMI of, yes, hold on a minute. It is coding for subsequent STMI of anterior anterior wall. And below that, you can also see that it also includes subsequent anterior apical transmural infarction. So yes, this is what the patient is currently having and in the hospital for the treatment, and that is to be sequenced first. Yes, option D is sequencing I-22.0 first, and second we are having I-21.11, which is for STMI or involving right coronary artery. Again, cross-checking with our scenario, the keywords: yes, the patient had an acute myocardial infarction of right coronary artery 2 days before. So that is the correct sequencing order. Yes, option D is having the correct sequencing order. Now let's see still what I 21.09 coding for, which is in the option A. This one is coding for STMI involving other coronary artery of anterior wall. So this is not specific, right, coders? We're having a specific code in I-21.11. So option A is wrong, and the correct answer is going to be option D, I-22.0, I-21.11, and there's your answer. How was that scenario, Chorus? Let me know in the chat. How are you feeling? Are you following? Is the explanation helping you? Yes, a lot of yes in the chat coming up. And let's move on to the next exercise. Okay, your options are option A, I-50.22, I-50.32, option B, I-50.23, I-50.33, option C, I-50.42, I-50.43. Melanie returns to her cardiologist office for the treatment of her chronic combined heart failure. So you got 2.5 minutes, and I'm sure this one you're going to answer before the time ends. Okay, and let me have a look at how are you all doing. And yes, I can see only one alphabet so far in the chat. That means you all are doing an amazing job. So the patient is at the cardiologist office for the treatment of chronic combined heart failure, and the correct answer is going to be option C. And this is how we got the answer. Yes, let's look what I50.2 coding for. It's the category, it's coding for a category asystolic heart failure, systolic congestive heart failure. And the code I50.3, the category code, is coding for diastolic congestive heart failure. So coders, I got a question for you. We also have a code in I50.4, which is coding for combined systolic and diastolic heart failure. So if we are having a combination of both systolic and diastolic heart failure, do we need to code the systolic and diastolic heart failure separate? That's a question for you. No, we don't have to code systolic and diastolic heart failure separate. So option A is wrong. Yes, it's combined. So option A is wrong, option B is wrong, and option C is coding for I50.42, which is for chronic combined systolic and diastolic heart failure. And I50.43 is coding for acute on chronic combined systolic and diastolic heart failure. So do we have an acute on chronic combined systolic heart failure and diastolic heart failure in our scenario? No, we have a chronic combined heart failure. It's not acute on chronic, it's just chronic combined heart failure. So given that, option D is also incorrect, and the correct answer is going to be option C. Great work, coders. Yes, great work, great work. Okay, now let's move on to the 11th exercise. What's ICD-10-CM code best describe this scenario? The options are option A, Z87.891 I21.21, option B for I21.11 Z72.0, option C I21.21 Z72.0, option D I21.21 Z87.891. A 60-year-old former smoker presented to the ER with a complaint of 4 days of fluctuating pain in the right arm and chest with bouts of shortness of breath. He was admitted with an acute STEMI involving the left circumflex coronary artery. Which of the following ICD-10-CM codes best describes the above encounter? Once again, coders, you got 2.5 minutes. I can see answers already coming up in the chat. You guys are great. So your 2.5 minutes starts right now. Oh my God, you all are so fast. Amazing, Goddess. Great work. So the correct answer is going to be option D. And these are our keywords: 60-year-old former smoker, 4 days fluctuating pain, right arm and chest, bouts of shortness of breath. Patient was admitted with acute STMI involving left circumflex coronary artery. So our question: was there a previous AMI? Answer is no. Patient didn't have any previous AMI. So our code would be from I-21 category. And knowing that, I can eliminate option A, because I-21 should have been the sequence first, should have sequenced first. So option A is coding for Z87.891 as a principal diagnosis. That is wrong. And let's look at what I-21.11 is coding for. It is coding for acute myocardial infarction. And of which location? We had an acute STMI of left circumflex coronary artery. And I-21.11 is coding for STMI involving right coronary artery. So no, from our documentation, we are having a SCMI of left circumflex coronary artery, and I-21.11 is coding for a STMI for right coronary artery. Now this is wrong, so option B is incorrect. And let's look into the next one, I-21.29. Now this is coding for, yes, STMI of STMI myocardial STMI involving other sites. Once again, this is not a specific code, and I-21.21 is coding for, yes, I-21.21 is specifically coding for STEMI involving left circumflex coronary artery. So we are having a specific code here, so no need to code other specified sites, other sites. And option C is also incorrect. And option D is the correct one. And option D doesn't stop over there. We have to code for a former smoker code as well, because in the instructional note under the category I-21, it's asked us use additional code if applicable to identify the history of tobacco dependence. That would be Z87.891. And option D is the correct answer. I see many of you have selected the code based on that. Yes, based on tobacco use. Many of you eliminated on the basis of that. So that's great skills. That's great skill, eliminating the wrong answer. So for this scenario, the correct answer is going to be option D. So great work, coders. And quickly, I will move on to the next section. Next, we are going to study about another type of infarction, which is a cerebral infarction. It is also known as stroke. Yes. So what's a cerebral infarction? It is blockage of the cerebral artery. Yes. And cerebral infarction are of two types. You can see it's been shown in the PowerPoint. You can see it's an ischemic stroke is there, and hemorrhagic stroke is there. So what's an ischemic infarction? Ischemic infarction occurs when the blood supply to the part of the body is blocked, preventing the oxygen and nutrients from reaching the tissue, and this will cause the tissue to die. And at the same time, hemorrhagic infarction causes when the blood vessels in the body ruptures and causing the blood to leak into the tissues, and this also will cause the tissue to die. So it's time to look into some guidelines regarding the cerebrovascular disease or infarction. So the first guideline is on C9.1, which states about the sequela or cerebrovascular disease, sequela of cerebrovascular disease or late effects of the stroke. So if a patient suffers from a cerebrovascular disease, he may have a neurologic defect due to the cerebrovascular disease, and that may be present maybe from the onset or arise even at a time after the onset of the condition. So that's called as a sequela or a late effect of a stroke. So if a patient is presenting with a sequela of cerebrovascular disease, the sequencing order to be followed is like this. Code first I-69, which is for the sequela of cerebrovascular code, and second you have to code for I-60, a code ranging from I-60 to I-60.67 if documented. Now I-60 to I-67 codes for the cerebrovascular disease. So that's a very rare scenario when you will encounter such cases. So always remember, only code from I-60 to I-67 if it is documented. Let's move on to the next guideline, which is C9D.1, and that states that sequela codes for the cerebrovascular disease that specify hemiplegia, hemiparesis, and monoplegia identify the affected site as a dominant and a non-dominant. So should the affected site be documented but not specified as a dominant or non-dominant, and the classification system does not indicate a default code, the selection must be as follows. So if the site affected, if the sequela, the site affected is being documented, but it's not said whether it's a dominant or non-dominant, we have to select on the basis of these guideline which has been provided. So if the right side is affected, the default is dominant. Yes. So if the left side is affected, the default is non-dominant. And for ambidextrous patient, the default is the side which is affected. Yes, for ambidextrous patient, they have both left and right side as dominant. So the default side would be the side that is affected. So with that, let's move on. And what are we having next? We are going to test our knowledge on the CVA guideline. And this is your 12th exercise. So what is ICD-10-CM code for the scenario? Options are option A, I-69.351, I-63.9, option B, I-69.353, option C, I-63.9, I-69.351, option D, I-69.341. After suffering a cerebral infarction, patient continues to have right-sided hemiplegia that is diagnosed as late effect. So coders, quick 2.5 minutes for you to solve the scenario. Great work on that guideline based scenario as well, coders. So quickly, I will highlight the keywords here. Patient is suffering a cerebral infarction and continues to have a right-sided hemiplegia. The patient has been diagnosed as a late effect. So option C is incorrect because we are going to follow the guideline C9D1, which states that when there is a sequela, we have to code I69 first, which is a sequela code, and followed by I60 to I6 code from I60 to I67 if documented. So option C is not coding I69 as first, which is a sequela code. So straight away it's wrong, and remaining all the options are coding for the sequela. Yes. So let's look what I69.341 is coding for. Yes, I69.341 is coding for a monoplegia of left lower limb following the cerebral infarction affecting right dominant side. So did we had a monoplegia in our scenario? No, patient is suffering from a hemiplegia and it's not a monoplegia. So option D is incorrect, and yes, option D is incorrect, and option A and B is coding for I69.353, which is, okay, let's look. I'm sorry, option A is coding for I69.351, which is hemiplegia and hemiparesis following cerebral infarction affecting the right dominant side. So in our scenario, the affected side is documented. And which side is affected, Cordis? It is a right side. The patient is having right-sided hemiplegia. So it hasn't documented as a dominant or non-dominant. So as per the guideline, yes, over here it states that should the affected side be documented but not specified as dominant or dominant non-dominant, we are going to follow these guidelines. So right side is affected and the default is going to be dominant. And moreover, option B is also not coding for the cerebral infarction, which is I63.9. Yes, it's also not coding for I63.9. And the documentation, it's been mentioned that patient is suffering from a cerebral infarction as well. So that will help us eliminate option B, and our correct answer, as most of you have said, is option A. So great work, coders. So quickly we'll move on to the next scenario as well. I'll read the answers first. Option A, I63.429, I69.321, Z86.73. Option B, I63.9. Option C, I63.9, I69.321. Option D, I63.321, I63.9. A 56-year-old male was admitted today for a CVA. He has a dysphagia as a result of previous CVA 2 years ago. What is or are the ICD-10-CM code for this encounter? So coders, quickly, let's solve this one. You guys are great. It was a great class, and you all are superb in this class so far. So the keywords are 56-year-old admitted today for a CVA. Dysphagia. Patient is having a dysphagia as a result of a previous CVA, which happened 2 years ago. So let's quickly look into option A, that is coding for I63.429, cerebral infarction due to embolism, unspecified anterior cerebral artery. So coders, is the reason of the CVA mentioned? No, it was not mentioned in the scenario. So we can code for a cerebral infarction due to embolism of unspecified anterior cerebral artery. Also, the code Z86.73, which is coding for personal history of a stroke unspecified without residual defects, is also incorrect, because in the documentation it was mentioned that the patient is suffering from a dysphagia that was a result of a previous CVA. So it doesn't make sense. Yes, patient is still having the residual defects. So option A is incorrect, and option B is also incorrect, because it is not coding for, yes, it's not coding for a sequela. It doesn't code for a dysphagia, which is due to previous CVA. So option A and B is incorrect, and remaining options are C and D, and both are only different in terms of their sequencing order. So what is the reason for encounter coders? Why is patient here today? The patient is here today for, yes, he's here today for the CVA and not for the treatment of the sequela of previous CVA. So the I63.9 should be sequenced first, followed by I69.321, which is a dysphagia following cerebral infarction. So option D is incorrect, because that's coding for I63.21, which is a sequela code first, followed by the cerebral infarction code, because the reason for visit or reason for the encounter is CVA. So option D is also incorrect, and the correct answer is C, I63.9 and I69.321. Sorry. So that's our answer. And how did you do, coders? How are you feeling after the class? So if you got it, it's superb, and if you missed it, but you learned something, as Miss J say, it's called priceless. Yes, it's priceless. So I before going, I want to say, when the life gets you down, you know what you got to do? Just keep swimming. But I will change it a little bit here. In a coding world, or in AMCI, when life gets you down, and you know what you got to do, you just got to keep coding. Yes, that's how coders say. So with that, we would wind up the class for today, and thank you for joining us. And on behalf of my team, Ms. J and Dr. Cynthia, I would like you to thank, or like everyone to thank you for joining us, and stay safe, keep coding till we see next week. So have a great week, coders. Thank you and bye.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around.